Hello everyone, I am Dr. Ashna, Assistant Professor, Department of Prosthodontics from Vinayaka Mission Shankaracharya Dental College. Today I will be covering the topic on abutment tooth selection in FPD. So these are my contents. We will be discussing about introduction on abutment, definition, certain criteria for selecting an abutment, clinical examination, radiographic examination and diagnostic cast examination before planning for an abutment, conclusion and references. So basically parts of an FPD includes pontic, the tooth which we are going to replace, then the connector, then a retainer and an abutment. Abutment is nothing but the tooth which you are going to prepare and which is going to serve as a support or which is going to retain a prosthesis. So if you see in this picture, this is the abutment tooth and this is a pontic which is going to replace the missing tooth. The retainer will be over the abutment tooth. Connector is a junction between the retainer and the pontic. So in an FPD, abutment plays a vital role in taking the forces in a total FPD unit. So forces acting in the entire FPD is transmitted to the abutment either from the pontic or from the abutment or retainer itself. So selection of an abutment is very important and it's a crucial step in success of an FPD. And there are various factors in selecting an abutment, so that we'll be discussing today. So according to GPT 10, abutment is nothing but a portion of the teeth that serves to support or retain any prosthesis. So if you see in this picture, this is the abutment which is used to serve as a support or retain the entire prosthesis. So according to Johnson et al. In 1965, they gave certain factors for selecting an abutment, which is very important factor, and all these factors has to be considered when planning an FPD when selecting an abutment. So we can have mnemonics to remember all the factors given by Johnson. So you can remember it as Camp Rose. So Camp Rose altogether is a certain factors which Johnson et al. Considered to be a primary or crucial factors for a success of an abutment. So I told you mnemonics will be Camp Rose. First we will be seeing Camp. Under Camp there are three factors, that is a crown length, crown form, crown root ratio. Under A there are five factors, Anti's law, axial alignment, arch form, alveolar ridge form, age, and under M we have two factors, mobility of the tooth and mutilation of the tooth. In P we have five factors, pulpal health, phonetics, pedial health, prognosis and psychology of the patient. So this is Camp. So in C we have three factors, A we have five factors, M two factors, P five factors. Next remaining factors will be rows. So R we have two factors, that is a root length and root form. In O we have occlusion as a factor taken by Johnson et al. In selecting an FPD. In S1 we have span length, E we have one factor, that is aesthetics. So all these factors contribute for the selection of an abutment tooth in an FPD. So before we go into the abutment selection, we have to go on with a clinical examination. Entire oral cavity has to be examined, not only the FPD region which you are going to treat. Then a radiographic examination of the edentulous site and the abutment tooth which you are going to consider. Then a diagnostic cast examination of the patient should be evaluated before going on with an FPD treatment. In clinical examination, we have to see whether the abutment what we are choosing has adequate crown height or not, or we have to see the inclination, how much it is inclined or it is in a correct vertical axis or not, the occlusion, whether the opposing tooth is supraerupted or not, mobility of the tooth, periodontal condition of the tooth, any attrition present, any caries are present, either it can be a caries in enamel dentine or a root caries or any cervical abrasion. All these factors have to be considered first before we could go on directly for planning an FPD. Then radiographic examination, we have to evaluate the edentulous site and the abutments which we are planning. Abutments can be either primary abutment or secondary abutment. Based on the multiple factors, we can choose either single abutment is sufficient or not, or multiple abutment is needed to go on for a long prognosis of an FPD. So radiographic examination, suppose if this is missing, we have to see for any caries in the abutment teeth or how the bone support is there any bone loss, be it a vertical or horizontal bone loss, crown to root ratio, morphology of the crown, length of the crown, the pedial space, then if patient has undergone any root canal treatment, we have to assess the CT done, which is either in a axis swelling or there is any periapical lesion. Then the pulpal outline can be assessed with the radiograph. Then any periapical lesion present or not, presence of any root resorption or any bone defects in the region of the FPD. After the clinical and the radiographic examination is done, we have to take impression of the patient, porocast, and do a diagnostic mounting. Diagnostic mounting and evaluation is very important in the success of an FPD. Here we can see the inclination of the tooth form and contour, either it's going to be over contoured or it's going to be in the correct size which you're going to plan. Occlusal relationship, where the pontic is going to come, or in your existing abutment occlusal relationship. Then the arch form, tooth alignment, and inter-ridge distance. Once all these factors are considered, that is after clinical examination, radiographic examination, and diagnostic cast examination, we can go for individual factors which we'll be discussing here. First is a crown length. So crown length is very important in choosing an abutment. If the crown height is less than 4 mm, we cannot take it as an abutment, because if there is more of crown length, a clinical crown height is more, it might be due to recession or it might be due to any periodontal problem. If the tooth clinical crown height is more, that is going to cause more leverage action and there will be more torsional forces in the abutment tooth, where the prognosis is questionable later. So always we have to remember the clinical crown height should be not less than 4 mm. Too much of height than 4 mm also will lead to more of torsional forces. Next factor to consider is the crown form. If suppose the nearby teeth which we are planning for an abutment, or the opposing teeth has a well defined cusp with tall cusp, there are a lot of stresses going to be anticipated in the abutment tooth. So we have to plan either the abutment is sufficient to take up all the loads or not, or we need an additional abutment or a secondary abutment to go ahead with an FPD. So one more thing to be considered is there should a pontic with a larger occlusal table also will exert more stress on the abutment tooth. So that also, in that situation also, we have to think of a secondary abutment. Next is a crown root ratio. Crown root ratio is nothing but measurement of the crown length which is seen above the alveolar bone and comparing that measurement to the length of the tooth which is embedded into the bone. The ratio is calculated. So it is considered that 2:3 ratio of crown to root is ideal for an FPD to go ahead. 1:1 is least acceptable. Anything beyond that, if the crown height is more than the root height, we cannot consider it as an ideal abutment. Next is Ante's law. Iron H. Ante in 1926 proposed this law. This law is nothing but the perisegmental area of the abutment tooth, which means the abutment tooth perisegmental area. The perisegmental area of the abutment tooth, which is blue in color, should be equal to or greater than the perisegmental area of the missing tooth which we are going to replace, which is brown in color. So let me explain. Suppose the second premolar and first molar is missing. We are going to consider the first premolar and second molar as an abutment. So the perisegmental area of the first premolar and the perisegmental area of the second molar should be equal to or greater than the perisegmental area of the two pontic teeth which we are going to replace. If it is not greater, the success of an FPD is questionable. Next factor to consider is an axial alignment. Axial alignment is nothing but the long axis of the tooth, how it is either straight or inclined lingually or inclined labially or buccally. So up to 25 degree of tilt can be modified with a full veneer preparation. If the tooth is tilted to up to 15 degree, it can be modified by a resin modified bridge FPD design. But anything beyond that cannot be compensated or modified using after the preparation which is used for an FPD. So in case of severe inclination of the tooth, be it either lingually or buccally, we can think of prosthodontic treatment options like mesial half crowns, telescopic crowns, cross pen and wing crown, up to 25 degrees only, and anything beyond that can be corrected either with orthodontic management or it has to go for extraction. Next is the arch form. So wider the arch form, there will be wider force distribution. So in this two picture, this first picture has wider arch form and this is a narrow arch form. So in this picture, if there is second premolar and a first molar missing, I can take first premolar, canine and a molar as an abutment tooth, which is sufficient. But in case of a tapered arch, we have to think of an additional abutment. Sorry to tell, in this first picture we can take only the first two abutments, that is the first premolar and the second molar as an abutment if the arch is wider. But if the arch is narrow or tapered, we have to consider an additional abutment other than the primary abutment. So in case we can take this canine as a secondary abutment. So in curved arches or taper arches, the abutment what we are going to use should be taken as canine as a support if we are replacing a clinical situation like this. Next is the alveolar ridge form. So as we all know, the alveolar ridge should be wider and it should be flat to take up most of the forces, be it a CD or an FPD or an RPD. In FPD also, a flat and wider ridge is very ideal to take up forces, or it's going to distribute the forces equally onto the abutment and onto the ridge also. So in case of a thin ridge, the pontic height is going to be more, which will act additional forces to the abutment tooth, and the abutment's life is questionable if the ridge is thin and the pontic height is going to be increased. So ideally the alveolar ridge should be flat and it should be wider to take up loads. Next factor to consider is the age. So as we all know, younger patients are aesthetically demanding patients. One more thing to consider in younger patient is the pulpal exposure during preparation. Basically, the pulpal outline of the younger patient is going to be wider, close proximity to the area where we are going to do a tooth preparation. In an older patient, the pulp outline is going to be narrow as compared to an younger patient. So pulpal exposure in a vital tooth preparation is going to be more in a younger patient when compared to the older patient. Another thing to consider in an older case is that there might be cervical abrasion in the older patient, and because of attrition the crown height is going to be reduced in the older patient. So in this picture, if you see, the crown height is reduced. Can we take this as an abutment tooth without treating the abutment tooth prior to the preparation? No, we cannot. So in this situation, we have to do either crown lengthening and we have to proceed with the FPD. Next, another factor to be considered is mutilation. Mutilation can be either caries affecting the tooth, or erosion of the tooth, or cervical abrasion, whatever it is. Anything damaging the tooth structure can be considered as mutilating factor of the tooth. So occlusogingival height, as mentioned, it should be 4 mm. Anything less than 4 mm cannot be taken as an abutment tooth. Either we have to go for post and core treatment, or we have to go for crown lengthening tooth treatment to consider it as an ideal abutment. So if there is root caries in any tooth, if root caries is present, we have to only extract the tooth. We cannot save the tooth. Next is mobility and periodontal health. To consider a tooth as an ideal abutment, the periodontal health should be very firm and strong. Be it either there should not be any bone resorption, there should not be any gingival recession, mobility, furcation and pocket involvement. If the teeth has firm periodontally, it is considered as an ideal abutment. But teeth will have grade 1 mobility. Should we go for extraction? No, you can consider it as an abutment, but it requires an additional secondary abutment to prolong the life of an FPD. In case of grade 3 and grade 2 mobility or furcation involvement, pocket involvement, it is contraindicated to taken as an abutment tooth. It should go for only extraction. Next is a pulpal health. Ideally speaking, the vital tooth will have better proprioception than the non-vital tooth, which means if we prepare a vital tooth, the proprioception or the load distribution is going to be better when compared to the non-vital tooth. But non-vital tooth, if it is asymptomatic, it can be RC-tethered tooth which is asymptomatic, it can be considered as an abutment also. Any teeth has been untreated, we can advise for root canal treatment. If the root canal treatment is asymptomatic, it can be considered as an abutment tooth. So in this picture, we can see generalized attrition in the lower arch, but we can do root canal treatment, post and core treatment for the tooth, then we can go ahead with an FPD. Next is psychology of the patient. Some patient with more stress will have the parafunctional habit like bruxism. In case of bruxism, we have to go for a splinted crowns, or we have to take an additional abutment, secondary abutment for even force distribution. Next factor to be considered is the phonetics. So for phonetics, the tooth length and the tooth contour is very important. In areas where the pontic height is too much or the bulkier crown is placed, phonation will be affected. So phonetics is an important factor based on the pontic length or the tooth form and contour. Phonation will be affected in the patient. Next important factor is the root length and root form. Longer the root, the force distribution, the larger will be the surface area, the force distribution is going to be more. Anterior tooth with a triangular root configuration will take up the lateral loads, whereas in posterior tooth with cylindrical root configuration will take up vertical load. So first we have to assess the occlusion and the load distribution, then we have to plan the FPD abutment selection. So basically, longer root, triangular root is favorable to take up loads. Next is the curvature of the root. Than straight root, curved root will take up more force, and the force distribution is going to be more because the surface area is going to be more in that area. So curved root is preferred than a long straight root. And one more thing to be considered is if the labiolingual portion or labiolingual width is greater in the root area, the abutment is going to be taking up more forces without harming the abutment tooth itself. One more factor to be considered is flared root. If the roots are flared up or separated apart from each other, it is preferred than a fused root because the surface area is going to be more, the load distribution is going to be more. Next factor to consider is the occlusion. In an FPD, if patient is having a mutually protected occlusion, we can encounter only minimum lateral forces. So single abutment is sufficient. But if you go for a group function, if patient is having a parafunctional habit, secondary abutment should be taken into consideration when planning an FPD. So always occlusal condition of the patient should be evaluated in clinical examination so that we know what type of occlusion the patient is having. But the single abutment and secondary abutment selection is based on all the entire factor which I discussed before. Not just because it is mutually protected occlusion, we cannot go for a single abutment if that abutment is not sound. Next is a span length. Longer the FPD span, greater will be the flexion. Basically it is said that only 2 tooth can be taken as a pontic so that the flexion can be withstand by an FPD processes. More than 2, that is 3 or more than 3 tooth is being replaced in an oral cavity, the flexion is going to be more, so the FPD might get fractured in long run. This is an example. Here 2 teeth are missing and this is a 4-unit FPD. The flexion is going to be 8 times greater than a 3-unit FPD. Next factor to be considered is aesthetics. So I told you aesthetic is a very important factor when we are coming in replacing an anterior teeth. So longer connector in the anterior, can you see this picture? The connector is longer, but can you see in this picture the connector is shorter, which is aesthetically pleasing. This one, because we give place for the pink aesthetic to play a role, but in this case there is no pink aesthetic, the tooth is going to be appearing bigger and bulkier, which is unaesthetic. So always avoid longer connection or connector area in an FPD. In patient with diastema, there are FPD options of giving a loop connector so that the tooth contour, that is the length of the tooth and the width of the tooth can be made apt for the patient than giving a wider tooth to close this diastema. So in diastema case, we can have a loop connector in an FPD design. So there are various factors to be taken into consideration in a selection of abutment tooth. So all these factors has to be taken seriously into a consideration, because abutment is one of the major component in an FPD that's going to take more forces in a full FPD unit other than the pontic structure or a connector region. So multiple factors which I have discussed above should be taken into consideration while selecting an abutment. So abutment selection doesn't come when preparing the tooth, it has to come in the planning phase itself. So how many abutments you are going to plan, one or secondary abutment you are going to take, is very important at the preliminary phase, when planning phase itself, than calling the patient and telling, no, this tooth won't take up, we are going to do an additional tooth, we are going to take that tooth as an abutment. No, all this should not be told in a last moment. So abutment selection is to be done at the initial planning phase itself, based on the clinical examination, radiographic examination and diagnostic cast examination. So multiple factors to be considered in selecting an FPD. These are my reference. Thank you for watching my class.